Next question, how will patients with Lyme disease likely present to primary care? Well, the very simplest way they would present is if they had a tick on them and they wanted you to pull the tick off. This is a very unusual situation because most people do not remember having a tick, but if there is a tick, it's important for a GP to understand how to remove the tick. A second way they may present is a classical description, the ECM rash, which is a bullseye rash. While some literature says that it is very common to have a bullseye rash, the reality is it ranges between 30 and 70%, and it may not be the classic bullseye rash, but this is another presentation that is commonly mixed up as being a dermatitis, being a fungal infection, or being a cellulitis. Tends not to be itchy. Another condition that people could present, obviously, is if they had a tick bite in the past, sometimes months, sometimes years ago, and now they have multiple organ system disease. So not just brain fog and migratory arthritis, multiple different symptomatology. And this symptomatology tends to be waxing and waning. So it changes quite commonly. So a history of a tick bite, a history of a rash, it doesn't have to be presenting with a tick bite or presenting with a rash. This history can go back for years and years. So it's important to ask. However, the most common thing is people present with multi-system non-specific disease that changes up and down and up and down. So migratory arthritis is one of the classic presentations. Patients often have migratory arthritis that I think changes as patients' immune system is better and worse. So you may have stabbing pains, you may have head pressures, you may have pains in your shoulder, pains in your joint, you may have palpitations, you may have pleuritic chest pains, non-specific symptoms coming from the brain, inflammation that patients describe as brain fog, concentration problems, energy problems, sleep disturbances, and sometimes mood changes that they didn't previously have. Now, everyone talks about syphilis as a great imitator. Historically, Lyme is a great imitator. So a number of patients who have already been put into another category, for example, ME, atypical rheumatoid arthritis, fibromyalgia. While not every case of fibromyalgia or ME obviously is Lyme disease, the appropriate history should be taken. And then sometimes people present with a history of Lyme disease, their Lyme test is negative, and they present to the GP with these, what people call non-traditional or private testing done. And I think it's important to GPs to understand what these tests are. In Ireland, the COVID tests were all sent to German laboratories to be tested. And unfortunately, when patients send a Lyme test to Germany to be tested in the exact same laboratory, they're told that the tests are not accredited, the laboratories are not accredited. So I think it's quite important that GPs understand more about the characteristics of these private tests that are being done before they dismiss the patients.